Good evening and good morning for some parts of the world, and welcome to the first Coronary Interventional Octagon case competition. This is a new series from CVI. There was already one episode in peripheral disease, but it's the first one in coronary disease. And this one is based on imaging and physiology-guided PCI. As you all know, the new ACS guidelines give class 1 to imaging finally. So there's a lot of excitement right now, momentum for this, for using physiology for guiding PCI. The goals are to use those tools in the best possible way. This is a CME webinar. You can get CME whether you watch it live now, but it will also be posted and can be watched later on. We have a tremendous, highly experienced panel with Dr. Rhian Davies, Dr. Yader Sandoval, and Dr. Arnold Seto, and 4 case presenters who are the finalists. These are already have won in a way because they all get a travel grant for CVI, Dr. Ahsan Ali, William Earle, Samantha Espinosa, and Ahmed Kamal. These are the disclosures for the faculty, and we would like to acknowledge the support of Abbott, Boston Scientific, Cordis, and Medtronic for making this webinar possible. For CME, you can log in if you can go to the CVI website, and you can log in and get CME for attending. And there's another one for those of you who are structurally inclined. The next Octagon is going to be structural. The submissions are already open, and the topic is transcatheter mitral therapy. Also, if you like what you see today, or even if you don't like it, there's another webinar that is coming up in a couple of weeks. This is on the best PCI case of the past year. Tremendous presenters, and they're going to share their best or worst experience from PCI from the last year. And finally, in July, we'll have the CVI in Austin, Texas. It's going to be nice and warm, and we look forward to having you all there in the summer. So thank you so much, and I think we're going to kick off with Dr. Ali. Dr. Ali, looking forward to seeing your case.
Thank you so much, Manos.
Okay, Untangling the String. Great title to get started.
Thank you so much. I'm Dr. Ahsan Ali from National Institute of Cardiovascular Disease, Karachi, Pakistan. Good evening, everyone. Here in Pakistan is 7 a.m. So from my side, good morning, everyone. So my title of my topic case is the Untangling the String. This is the full of new challenges and also capable of curiosity. I have nothing to disclose. So 70 years old male, hypertensive status post-primary PCI to LAD 20 days prior. He is non-compliant to medications. He presented to the emergency department with chest pain of 2 hours and diagnosed acute anterior wall MI and suspected stent thrombosis. On the basis of the ECG, so we decided to proceed for catheterization. The femoral access was taken, right system engaged, showing non-obstructive. As suspected, so we confirm through coronary angiography, the left system is totally LAD, proximal LAD is totally occluded. There's a confirmed subacute stent thrombosis.
Perfect. And maybe we could ask Dr. Seto, of course. Dr. Seto, as you know, he's one of the gurus and masters of arterial access, and he's probably wondering now about radial versus femoral access, and that's obviously a eternal question. But Arnold, what do you think about the access? And maybe we can have Dr. Ali address that.
Sure. No, patient has already radial access. That primary PCI was already done through the radial access. His radial pulses was weak. That's why we went for femoral access.
Great reason. Of course, the guidelines suggest that if you can get access within 3 to 5 minutes, then you should try radial, and that the benefits are overwhelmingly beneficial compared with any delays in STEMI response time.
So we decided for PCI. So workhorse wire parked in the LAD. After that, on the basis of patient present to the emergency department without any record. So that's why on visual estimation, the operator decided to take 3 Senfitrol and C balloon. But it was uncrossable through the stents. So that's why he which position whichever is the maximum he can achieve at the proximal portion, he inflated the balloon at the nominal pressure. After that, that was something different. Here you can notice if you have eagle eyes, you can appreciate this is the
So maybe Yader, I mean, what do you think? You have an acute STEMI, instant thrombosis, and you have the wire through, the balloon doesn't go. So what would you suggest to people to do, and what goes through your mind when you encounter this situation?
No, the balloon was taken that couldn't cross completely through the stent. But finally, to achieve the flow earliest possible, so operator inflated the balloon at the proximal stent in the nominal pressure, on the nominal pressure.
Perfect.
And Ahsan, I had a question for you. Nice presentation. So I thought it was interesting that you guys usually use diagnostic catheters in a STEMI. It seems like you guys were using a JR and a JL there, the initial catheters rather than the guide. Was there a particularity that made you guys use diagnostic catheter first rather than a guide?
So here in we especially this is the we usually do in angiography first after the primary that's STEMI. After that we do to keep the guider.
Yeah, I guess I think what Dr. Samla was saying is that why not go straight here? It's going to be an anterior MI. So once you shoot the right, why not go with the guide directly and save yourself the time and changing the catheters for?
Yeah, that's a good option. But operator decided first in the diagnostic catheter. And after that, he took the guide catheter.
Perfect. And then I think for the audience in general, at least my approach to this has been, if I have a stent and then I wire through the stent and then the balloon doesn't go, the first question that comes to mind is that maybe the wire went under a stent strut, and that's why the balloon is getting stuck. So one of the first things I would do is get a looped wire to get through. But let's see how the case unfolds.
Yeah, actually, if you look back on the prior image, the wire seems slightly outside of the vessel injection.
Yeah, this is the first clinical challenge. You can appreciate the wire is behind the stent.
Perfect. Again, sometimes it may be hard to see it on the image, but yes, I like your graphic there showing the stent on the wire.
So in the image, that's and the arrow shows that this is a clear wire is behind the stent.
I will admit that if I could jump in, that this is the reason sometimes, and there some people that will purposefully try to do this like all the time if they can, is like to just get a nice loop, and just push it through this. So there's a lower likelihood that this happens.
So apparently, stent was fully opposed, and then the angiographic view that was fully. Operator the operator didn't know that the wire is behind. After that, balloon was inflated. Then looked closely. Then we felt that the wire is behind the stent. So the second challenge was after the NC balloon inflation, there was deformation of the stent proximally. That means a balloon was inflated behind the stent. That's why stent deformed. You can appreciate that in the image. This is highlighted. This is the behind the.
And clinically right now, how is the patient doing, like hemodynamically?
The hemodynamic patient was fine. Pressures, heart rate was okay. But patient has STEMI, that's fine. Her heart rate 100 beats per minute. The pressure was fine.
Okay.
So what's the next? What's the next best step to tackle with this situation? Should we rewire, or we crumple the whole stent? Our third option was we should look in other views to confirm that our wire is behind the stent, and through IVUS catheter we will confirm that we are inside or we are outside the stent. So we opted for third option. First, we have to confirm wire is within the stent or outside the stent. So after that, IVUS was taken, which shows you can appreciate here this from distally. Stent is wire is through the stud, and now in the proximal, you can appreciate the stent is deformed in the crescent shape.
Wonderful. I guess that's a great example of how intravascular imaging can confirm. I guess you did have a strong clinical suspicion based on the angiogram, but this is nice to confirm it. And also gives you the size of the vessel, right? This is what, a 4.0 vessel.
Yeah.
And possibly this was underexpanded.
Stent was yeah.
Which
That's
is actually
why
interesting. Yeah, because they say that. Sorry, go ahead.
So wire went behind the stent. So it was confirmed. And after that, we rewire the rewire. And we, after many attempts, we were able to negotiate the wire through the stent struts. And you can appreciate there was a small balloon 2.0 that is free floating through the stent.
What wire did you use?
Yeah, BMW Brilakis wire.
Okay.
You know,
So actually, I'm curious.
I
don't know. Yeah, go ahead, Yader.
No, I was going to say one of the comments in the chat is it's a good one too, that whether you guys have any of the technologies to look at stent or device enhancement. I will admit that some of those technologies we're increasingly using. They're very helpful, you know, to sometimes demonstrate your stent.
But in the fluoroscopic view, it was clear that stent is deformed and wire is behind the stent. Then the IVUS confirmed it. That's actually the stent is deformed proximally, and wire initially went behind the stent, and in the distal part it was inside.
It reminded me, was the maybe I missed this in the presentation early on, but was image guidance, IVUS or OCT used in the initial PCI?
Yeah, it could be. It should be a IVUS guided PCI. From the stent thrombosis point of view, the first imaging is the IVUS to confirm the mechanism of that. But here in our setup, so we went for primary PCI, and due to a complication, we are unable to pass the balloon. That's why we confirm the wire after that with the IVUS. So here we rewire the rewire through the LED struts. And after that, we able to pass the small balloon. And here is it shot taken, which shows TIMI 3 flow, but still stent is full of thrombus.
Okay, one question that came up is, did you use a big balloon, small balloon? Sometimes you start with a smaller and you go to a bigger balloon.
Initially,
what balloon did you use?
After wiring, we took the small balloon to check we are inside the stent struts. It was free floating. Then we confirmed that we are inside the stent.
Wonderful.
Yeah. After that, we took a larger balloon, NC balloon, to post dilate the NC, but we were unable to cross the stent completely distally. So one of the it seems to be here some displacement of the stent struts. Our wire was actually apparently it seems to be within the struts, but due to displacement of the few struts, it went behind that struts. So we were unable to cross the larger size balloon. So IVUS was repeated. Here you can appreciate in the arrow that some struts are displaced inward in the image view.
Yeah, it looks like you're still crossed, right? It's not all the way through. Part of the stent is through, and part on the left, you're
due to
still
deformation.
under the stent.
Yeah.
Okay.
So you can appreciate these are thrombus, full of thrombus in the stent, in the IVUS image. So after that, we rewired the stent from the rewired, and we negotiate after many attempts. We able to negotiate with it, and finally we again rewired the LED. So the finally after that we confirmed with the IVAS that we are now within the stent. So now we were able to pass the larger size NC balloon, and now we post dilate the stent with 4-5-12 NC balloon. And after that, the fourth challenge, was angry clot phenomena. You can appreciate the thrombus in the stent and distal, and also the diagonal branches also occluded due to embolization.
Can I jump in? Can I ask you something else? This is a question just before, and again, it's a question. I'm not sure that they're right or wrong, but must one renegotiate getting into that stent channel? Is that needed? I mean, can you just like crush this thing? I mean, like, must one go through the struggle to try to get back through the stent? What's the rationale for that?
I'm not getting the question.
So he's asking why try to wire through the stent and not just take a new stent and just crush whatever portion of the old stent.
Yeah. It was the option. It was the option that we fully crush the stent, and after that we rewire and do a new stent. But we tried to as this is the only deformed portion was the proximal part, and it was not totally crushed. So with our strenuous effort, we could able to negotiate the wire through the stent struts. Then we plan for post dilate. That was not totally crumpled or deformed stent. That's why we opted for to rewire and post dilate it.
Wonderful. And you have embolization now. So what do you do?
Now we embolization is angry clot phenomena. After that, we took export catheter. And after 3 passes of export catheter, we again post dilate the stent with 508 NC balloon.
Great. Did you give 2B3 inhibitor? That's the one question that came.
Yeah. We also after that you can appreciate there's the thrombus over the distal part of the stent or proximal to the diagonal branch. Diagonal branch is totally occluded, so we decided to POBA the diagonal branch. Here you can see the final result. Patient was kept on tirofiban infusion. After the 4-hour effort, we could achieve the TIMI-3 fellow with the distal thrombus, and that was our final result, and patient was kept on tirofiban infusion. We planned for relook. After that, patient ST settled and chest pain relieved, but patient refused for further intervention. But he's fine, and he's on follow-up. He's doing well.
Perfect. Wonderful. Let's do last minute because we have to go to the next case.
Key learning points for the operator and team: be aware of wiring in the stent thrombosis patient, especially because they have the mechanism of undersized stent, under expansion, malopposition. Do not hurry to inflate balloon when it hasn't crossed the stent completely. Importance of stent boost technique. That was my faculty was this is raised in the question. That was the stent boost technique or stent enhancement tool. Machine resolution magnifying views are insight in such conditions. And the final last and but not least is the use of imaging. IVAS or OCT is mandatory in these cases, especially in the stent thrombosis patient. Now, I would like to thank my mentor, Professor Abdul Hakim, Dr. Khalid Bhatti, and Jahangir Ali Shah. Thank you so much.
Wonderful. Thank you again. Phenomenal case. Thank you so much for presenting, and give it to time. We'll just go straight on to the next case with Dr. Earle.
Okay. All right. Great. Thanks so much. My name is William Earle. I'm a cardiology fellow at the Oregon Health and Science University. The case today that I have for you is called Collateral Damage, the Case of a Bad Neighbor. Unfortunately, I have no disclosures. So we will get started with a 53-year-old male software engineer who presented to the Oregon Health and Science University cath lab for an outpatient coronary angiogram to evaluate ongoing CCS3 angina on medical therapy. I've listed his pertinent cardiovascular history below. I'll highlight that he had a normal left ventricular ejection fraction of 60 to 65% and no significant valvular disease. He does have a history of prior coronary artery disease with an NSTEMI about 6 months ago, for which he underwent a 3.25 by 18 millimeter Xience SkyPoint drug-eluting stent to the ostial ramus intermedius. Unfortunately, the films are not available as this was done at an outside institution. After the patient had this NSTEMI, he continued to have anginal symptoms with moderate exertion. He underwent a repeat coronary angiogram 3 months after his initial presentation. I have his films here. You'll see on the left an LAO caudal projection showing the patent ramus intermedius stent. He has some mild left main disease and some mild disease in his left circumflex. On the right, you see an epicaudal with, again, non-obstructive disease in the left circumflex and some mild disease in the LAD. And then here's one more image from that follow-up angiogram. Again, we're seeing the full extent of the LAD here. He does have a mid-LAD myocardial bridge, but otherwise no significant obstructive coronary disease. So following this, he continued to have anginal symptoms. His anti-anginals were up-titrated. He was on Imdur and metoprolol at the time. Those were both increased. He was also on aspirin and atorvastatin as well as amlodipine. He was referred to cardiac rehab and received treatment for acid reflux. Despite these interventions, he continued to have significant symptoms with mild exertion, and so this prompted a referral for a stress test. So he underwent a nuclear myocardial perfusion scan, and this is about 2 weeks prior to the ultimate angiogram that we'll review today. Here we see stress attenuation corrected images, which demonstrate a large area of severe perfusion defect in the totality of the septum, as well as the anterior wall and the apex of the left ventricle with stress. And I've highlighted those with some arrows.
Thank you for the arrows. I haven't seen one of this in years.
Yeah.
Question
You never know.
Question for
Yeah.
you. What was the original angiogram calling the LAD or septal region?
The initial angiogram, what did they call the LAD?
No, the angiogram right before this stress test.
Sorry, can you ask your question again?
This angiogram, what was reported as?
I think this was like 30% proximal, 30% distal left main, and like 20 or 30% proximal LAD. So it was felt to be pretty mild disease.
Great.
Okay, so we have our perfusion scan. Okay, so this brings us to, so after this stress, the patient was referred back again for another angiogram. So this brings us to today. Again, you're going to think that these are the same images. They're not, but they look very similar. So again, you can see that he has a patent ramus intermedius stent. Again, we see that he has some mild distal left main disease, some mild disease in his left circumflex, and some mild disease in his LAD. So despite being on multiple anti-anginals, he continued to have symptoms. I should have said that we did shoot his right system during both the 3-month follow-up angiogram and this angiogram, and it had showed non-obstructive disease. So this brings us to our clinical challenge. We have a 53-year-old male with CCS3 angina, a positive stress test, and he's now undergone 2 angiograms in the past 3 months without angiographic evidence of obstructive coronary disease. So given our concern for distal left main disease, we used intravascular ultrasound during the second angiogram to see if we could identify kind of what was going on here. Unfortunately, we met resistance at the ostium of the LAD, and so we weren't able to advance the IVUS catheter out from the left main, and so we had to abort that. So we're sort of stuck now with how do we evaluate an intermediate stenosis we've attempted IVUS. Angiographically, it looks okay. And I should add that we did attempt different angiographic angles, and we really weren't able to get better views of his anatomy due to the trifurcation anatomy approximately. Yes,
Which
Dr. Seto.
IVUS catheter did you try? Was it the Eagle Eye? In which case, often a rotational IVUS or OCT often crosses better.
Yeah, so unfortunately, we only have the Eagle Eye available in our lab, although there was just a lively discussion a week or two ago about working on getting some other options. So yeah, not an option in this case.
That's unfortunately very frequent across the country, that most people only have the Eagle Eye, and it doesn't cost that much more to have a rotational option on Philips, but it is available.
Yeah. Well, hopefully some of the folks from our division are listening today. Okay,
Can I ask a question? I guess, is that a sign? I mean, if you don't cross with the IVUS, then is it severe just by itself? I don't know, Yader or Rhian. I mean, if you have you cannot cross a vessel that doesn't look significant by IVUS, even if it's the Eagle Eye, I mean, does that mean it's significant?
I think it's a pretty reasonable bet that if you can't get it, particularly in a proximal vessel like this, as long as your guide is supportive, if you're having challenges, it probably means that you're meeting a calcified stenosis or some sort of eccentric stenosis.
I mean, a comment and a question. I mean, the comment is, yes, the solid state, IVUS Eagle Eye, it's a little bit more bulky. That being said, it is the only one that has angiographic co-registration, and you can even do tri-registration. So, there's always trade-offs in these technologies. My question is, why anatomy over physiology? Why start with IVUS? I mean, like you struggle with it, it didn't cross, but I'm uncertain why do you have to start with anatomy here?
Yeah, so I think it was primarily because of the concern for left main disease with an indeterminate lesion there. So we knew that the LAD was kind of the lesion that we were most worried, or the artery we were most worried about. But I think kind of, based on the class 2A recommendation for IVUS to evaluate left main disease, we pursued IVUS first rather than reaching for the physiologic testing.
Did you try to IVUS into the circumflex, in which case you were evaluating the left main per se?
Yeah, that's true. So initially, the IVUS advanced well in the left main, but then when we weren't able to cross into the LAD, that was the artery we were most concerned about. So we pivoted at that point. Okay, so here's our pivot. We pursued physiologic testing at this point. So we did instantaneous free wave ratio of the left system. There's just a picture of us wiring the LAD there. So in the ramus, the IFR was 1.0, and in the left circumflex, the IFR was 0.99. So then we went down the LAD. So we're feeling pretty good about the flow through the ramus and the left circ, which agrees with the angiographic images. Here is a pullback from the mid to ostial LAD, which shows evidence of ventricularization at the ostial LAD, suggestive of severe stenosis, which, we sort of figured that there was going to be a problem based on the IVUS. So the IFR number that we actually got was 0.18. So we were shocked by how significant this obstruction was. We repeated the measure several times and reliably got between 0.18 and 0.2. So ultimately, given how significant this hemodynamic obstruction was, we did not pursue further physiologic testing with FFR. I'll pause there. I don't know if Dr. Seto looks like you want to jump in.
I've never seen an IFR that low. I've never seen a 0.25 even. So to think that this is 0.18, despite angiographic mild disease, is very impressive.
As I said, we were shocked. So we'll get into it in a minute, but it was very, very shocking. Although it did correlate very well with the patient's stress test and his symptoms. Ultimately, we discussed the patient in our multidisciplinary heart team meeting. We talked about kind of a few different things that could explain these symptoms. none of them really made sense. So I mentioned earlier in the case, he did have a myocardial bridge, but it was in the more mid to distal LAD. And, you know, this is a 53-year-old male. So it didn't totally make sense there. We talked about vasospasm. And again, you know, that doesn't totally align given how long he's been having these symptoms. And so ultimately, we felt that his symptoms were most likely caused by external compression of the ostial LAD from the adjacent ostial ramus intermedius stent, and that this was given primarily from his trifurcation anatomy, and that there was probably some contribution from the mild distal left main stenosis. But the fact that his symptoms really never improved after that initial stent about 6 months ago was pretty concerning. So we did consider a complex PCI to fix this. There was concern that the PCI would require stenting back into the left main, converting the ramus intermedius stent into a 2-stent bifurcation strategy, and that there would be a risk of compromising flow down the left circumflex. So there was not a lot of appetite to pursue this course of action. Ultimately, the patient was referred for CABG, and he successfully underwent a Lima to an LAD bypass graft. And at 1 month follow-up after CABG, his symptoms had completely resolved. Yeah, go ahead, Dr.
Was that minimally invasive CABG, or was it open sternotomy?
It was open. It was an open sternotomy. Yeah.
Yeah, that seems like you could, if your surgeons were expert in minimally invasive, it would be a good candidate for that.
Yeah, no, that's a great point. I'm not sure how much familiarity our center has with that particular procedure. So with that, I'll kind of wrap up with a couple learning points. You know, IFR is a physiologic index. It's used to assess hemodynamically significant intraluminal lesions. It's calculated by measuring the resting pressure gradient across coronary lesions during diastole when microvascular resistance is low. And to Dr. Seto's point, you know, an IFR of less than 0.89 is considered significant. So this was a very significant IFR. And then IFR is a class 1 recommendation for angina, undocumented ischemia, and angiographically intermediate stenoses, and has been shown to be non-inferior to fractional flow reserve. And I think I would just say, you know, in our patient, you know, it's a 53-year-old male whose angina was being treated as acid reflux. This physiologic testing was truly life-altering and enabling a diagnosis to be made, an appropriate referral for CABG, and then ultimately leading to resolution of his pretty severe angina. And so with that, I'd like to thank Jeff Marbach and Coulter Wickern, who helped mentor this project, and happy to take any other questions.
Perfect. Go ahead. I'm sorry. Go ahead, Rhian.
I think it's great that, you know, you took into consideration IFR in both the ramus and the circumflex, because I think some operators may have just gone in and did the concerned area, which is the LAD. So it's always helpful, even and if the patient is going to ultimately go for surgery, that they don't get grafts put on in spots they don't need it for. So that I applaud you for that. I'm still surprised by how low that the LAD was, but that's good for the patient that they had resolution of their symptoms.
One question from the chat that I'll communicate: was CTA considered after cath at the 3-month mark because the trifurcation looks worse? And then one question I had to you, which is, do you have the microvascular assessment, and were you prepared to do so or refer them to a microvascular center in case your FFR was negative?
Yeah, so to the first question, we did think about CTA. The outpatient provider considered it. I think given the severity of his anginal symptoms at the 3-month mark, there was substantial concern. So sorry, I guess the timing of the question, are they asking about CT before the 3-month angiogram or after?
After the cath at 3 months.
After the cath at 3 months, yeah. So after the cath at 3 months, the outpatient providers felt that this was more likely non-cardiac chest pain, and so he was treated for acid reflux. They sent him to coronary or to cardiac rehab, and then given the persistence of symptoms, they went to the stress test after that. And when the stress test was floridly positive, he was referred back for angiogram again. And then the second question. I think that, yes, we probably would have considered a microvascular assessment at that point, given that we'd had now 2 looks at our system. We did the 3-month angiogram, and then we did the present one. So yes, I think we would have considered that referral as well.
Well, great presentation. Just one quick question. I'm just, I mean, clearly this was a great clinical course overall with the Lima providing a good long-term outcome and the patient having an improvement in the symptoms. I'm just curious. I mean, this is single vessel coronary artery disease that it's not overtly complex. Do you guys have a standard heart team approach for this sort of cases? So I think it's an interesting, whether with a single vessel coronary artery disease, you would do this in a routine basis.
Yeah, so no, almost certainly not. I think because of the his anatomy with the trifurcation of the vessels and the concern about how complicated the stenting procedure was going to be required in a relatively young and relatively active patient. That's why we sort of reached for surgery sooner than we would have if he'd been, say, 75, or if the lesion had been further into the LAD, or if the initial lesion had been further into the ramus, probably we wouldn't have had a problem with the LAD, but if the follow-up lesion was more distal in the LAD.
And the other quick thing is, I guess, I mean, Arnold's an expert in all this issues, so I will pick his brain. But Arnold, what do you think about IFR here with the bridge? Do you think that can influence or contribute to somehow this way lower values that are surprising to everybody? Does that play a role? As you know, a lot of people do like dobutamine IFR to unmask bridges, and here it's like 0.18. So I'm just curious whether you think that played a role. To me, when I see here the bridge and I see the lesion, it would be very nice to show IFR co-registration. But I'm just curious what you think, Arnold.
Yeah, I mean, a bridge can certainly create ischemia. My understanding was that this wire was not anywhere further down to record that bridge. I think it was pretty proximal. So at least that big step up, of course, it helps explain it, that it's not the bridge. So that can be reassuring. I think you go into bridges and spasm when you don't have a markedly positive IFR like this. So I think the answer was more clear in this case.
Perfect. Well, again, Dr. Earle, thank you so much. Lots of learning points. Sometimes I guess we know that angiogram is not always what you see, and that case makes perfect sense of that. So thanks for an excellent presentation. Just for the other presenters, we'll go over a little bit after the 1 hour mark, so don't feel rushed to present your case. And having said that, we'll move on to Dr. Espinosa for the next presentation. And I love the title for this. It's very provocative.
Awesome. Well, thank you so much to CVI and the panel for this opportunity to present. I'm Sam Espinosa, first-year interventional cardiology fellow at Brigham and Women's Hospital in Boston. So I'll be presenting a case from early on in this interventional year. I have no disclosures. So this is a case of a 45-year-old gentleman who presented to the ER for 3 to 4 days of stuttering chest pain. Found to have a concern for end-STEMI, with troponins peaking at 107, but with echo showing preserved VF, no overt regionals. Was also incidentally found to be COVID positive. Significant risk factors here, notably for uncontrolled dyslipidemia, active tobacco use, and then also did have an aspirin allergy as well. His presenting ECG showed sinus bradycardia with some inferior T-wave inversions, but no overt sort of acute ischemic changes otherwise, and he was otherwise stable. So he was admitted initially for medical management due to his stability and need for aspirin desensitization. So in the meantime, he actually did end up undergoing a coronary CTA, especially in this young patient, but which did confirm that he did have obstructive coronary disease, notably for 2 severe soft plaques in the proximal and distal RCA. And there was also this question of an occluded, very small second diagonal branch with a small lateral apical aneurysm, interestingly.
And I guess the point here is for all interventionalists attending that, we better start learning coronary CTA, and I'm sure the panel will agree as well, because the reality is many of the people down the line will be coming to us based on CT versus the angiogram as we're used to.
Mm-hmm. Yeah, absolutely. And then, of course, from a planning standpoint, we were able to confirm that, sort of the vessels were where we expected them in terms of, what catheters we might choose. Also looking at these lesions, not a significant amount of calcium, so thinking this should be fairly treatable, and hopefully just a quick in and out. So he ultimately made his way to the cath lab. We went right radial, 6 French sheath, 5 French diagnostic catheters, JL 3.5 on the left and JR4 on the right. You see that we have a short but normal left main with no significant plaquing in the LAD or circ systems. Our sort of areocranial view here does give us a sense that there is maybe some slightly sluggish flow in that small diagonal branch, but it's all very distal here where that plaque is. The proximal vessel itself is wide open. So not something that was really worth trying to go after. And then looking at the right side, we did confirm those two serial lesions, sort of very tight stenosis in the proximal RCA, and then that additional lesion in the distal RCA without extension into the RPDA. So at this point, we decided to move forward with PCI of the proximal and distal RCA. We stuck with our right radial 6 French system and anticipating possible need for support to deliver equipment more distally, went with an AL 0.75 6 French catheter. There was a little bit of resistance advancing the catheter into the root owing to some radial spasm, but we were able to ultimately get it down there with the help of our nursing team and some additional sedation. So we're able to engage.
Samantha, just a point here. Thank you for sharing that CT. And as Manos noted, this is of course an evolving field, but arguably some people would say that as we move forward, if you have the CT is a diagnostic tool that already. So here, I think you had like 6 pictures there. So arguably you could just say you could take like 1 picture of the left or 2 at the most and just go with a guide, since you pretty much already know what you're getting into. So just to make the point that I think this is how these things are moving forward to reduce radiation, reduce contrast. You know what you're going to find, and you can just go ahead and move forward with that.
No, absolutely. Point very well taken. I think certainly on the left side as well, because of this question of that diagonal, I think the team wanted to make sure we get a few different views to see if that was really something we can fix, although there was that small aneurysm. So suggested some chronicity already, which we would not have appreciated on the angiogram, but the CT did show. Yeah, point well taken. So went ahead and moved forward with PCI here. Took a Xi'an blue workhorse wire that pretty easily traversed into the distal RPDA here. And then went forward with a 2.5 compliant balloon for pre-dilatation. We took a puff to make sure that we were lined up distally and quickly realized that our balloon was actually occlusive, and this was a pretty tight lesion proximally. So recognizing this, started moving a little bit more quickly here to reduce our ischemic time. We dilated distally and can see reasonable expansion of where we thought the distal lesion was. But on pulling the balloon back to dilate the proximal lesion, we were having trouble with watermelon seeding and the balloon sliding distally with inflation, which was somewhat unexpected given how focal and soft that plaque was. So obviously in order to address that though, had to little by little back the guide up, and we were ultimately able to pre-dilate, shown in that third picture there. But as mentioned before, we had encountered some radial spasm. And so after deflating that balloon, unfortunately, our next picture is a nice disengaged guide, which had sort of released, I think, from the spasm that kind of caught up with the tension releasing from the guide. So at this point, as a fellow, I look over to the attending, apologize, attending steps in, but unfortunately, again, fighting this spasm, we weren't able to re-engage this guide, and actually ended up losing the whole system. So went ahead and switched strategies very briefly, went in with an AR1 6 French guide, something a little less aggressive than the AL. But despite antegrade wire escalation, we actually weren't able to recross this proximal lesion. And at this point, the patient started having chest pain, ST elevations. So decided we needed to just go ahead and switch strategies altogether. But the 2 main challenges facing at this point, of course, from a planning perspective, treating both proximal and distal lesions and what equipment you want going into that. And then 2, losing wire access after traumatizing the vessel with pre-dilatation, and then facing trouble with recrossing.
And we're pretty sure we haven't dissected the ostial, right? The aorta.
Well, we don't know about the aorta at this point. A non-selective quick puff as we were trying to re-engage showed that there wasn't, flow down the vessel consistent with the ST elevations we were seeing. Mm-hmm.
Did you switch femoral or you're still radial at this point?
Yeah, so at this point, we went ahead, again, just really having trouble with being able to manipulate these catheters at all. Decided to switch to groin so that we'd be able to use our equipment a little bit more easily. We also upsized to a 7 French system in case we would need, more support to deliver other equipment, realizing that we have vessel closure. So quickly got femoral access here. Again, we had used multiple wires to try to recross. And ultimately, we're able to send a Mongo into the proximal vessel. It formed a knuckle and then traversed into the distal RCA.
So was engagement easy with this AR1 guide?
It was much easier from the groin because we weren't fighting the spasm issue anymore.
Sure.
So,
and I guess one question that came through is why not go with the JR4, which may be less traumatic than the amplets, right?
Yeah, no, absolutely. So I think we're still balancing, again, knowing that we're going to have to deliver things more distally. And, that was sort of the main concern here. But certainly a JR with a guide extender, might have done the trick for sure. Mm-hmm.
Yeah, but then sometimes you're also left with that battle of kind of the guide swishing around in the aorta and deep seating at times, and you can end up having almost a worse outcome with the bad support, particularly from the radial. So AL.75 is actually my go-to from radial for most patients, but.
Perfect.
So our Mongo is in the distal vessel now. And then went ahead with Boston IVUS. And unfortunately, this confirmed that our wire had performed a nice ADR without the R, and it actually dissected all the way down into the distal RCA. So we went ahead and left this wire in place here. I don't have those images saved, but left that wire and attempted to parallel wire with a fresh Mongo. We're still having trouble wire going into the same plane here. So we went back and looked at the IVUS a little more closely, and we could actually identify where that wire entered into the dissection plane, which was very proximal, but there was still a landing zone between the dissection plane and the ostium. So based on that, we disengaged the guide a bit, pulled back, and then that allowed us to rewire into a different plane. And so this is the second wire that's in place. We had already removed the initial Mongo in this picture here, but taking the IVUS all the way down, this is what we saw, confirming that our second Mongo was indeed luminal, but then obviously showing a very extensive subintimal hematoma with that initial wire in that plane. And then again, the more proximal run here, just showing how short of a amount of running space we had from where the first wire was entering the plane.
It's an excellent point. So I'm just maybe for teaching purposes for the everybody here logged in and everything. So did you not just decide upfront not to inject anymore as soon as you decided that you had to do imaging? Okay, can you speak about that, the rationale, but there was no injections? You're saying you just number one step was to image.
Right, absolutely. So, we had that initial sort of non-selective puff when we were still radial. So we knew this vessel was gone and, suspected that we had dissected, whether from pre-dilating or the guide or combination. And so, yeah, a lot of times what we'll do in the lab is actually take off the syringe from our manifold so that we're not tempted to puff until we know really where we're at. So yeah, that's certainly something that we thought about. And I know sort of later in the case as well, as we have equipment in place, you also want to try to limit inflow into a dissection plane. So if you have balloons or a guide extender, sometimes pushing equipment into that space can kind of reduce that hematoma extending.
Yeah, this excellent maneuver, and I think many people also try to rewire this with a soft wire, and some actually argue the SUO 03, the softest wire available, might be a good choice to avoid getting in because the polymer jackets will have the tendency to go in. But clearly here you were able to get it in the right place, so that's awesome.
Mm-hmm. So with that, we were able to move forward with fixing my mistake here. Because of how extensive the hematoma and dissection was, we instead of where we would typically fix distally first and work proximally, we went ahead and decided to secure the proximal vessel first, so we wouldn't have to worry about having to rewire the system if something else were to happen. So deployed a 3.5 by 48 long stent, showing good expansion here where that proximal lesion was. Quick puff showing that we had restored flow and the patient was also starting to feel much better. We used IVUS again to figure out where the distal edge of that hematoma had extended to, and we were able to sort of plan the next stent here. Again, had trouble with delivery, and so did downsize our 7 French trap liner to 6 French guide liner, which we were able to inchworm down and ultimately deliver that stent. We do see that there's a little bit of a waste where that distal lesion was, and then taking a look, again, we see now more luminal irregularities distal to the stent edge, consistent with propagation of the dissection.
Yeah, and this is the one actually that, although I see your point, sometimes putting the distal stent first may be the way to go to block the hematoma sort of from milking and traveling further down.
Yep, absolutely. So went ahead and secured that, again, having to use that guide liner inchworming down to deliver a 2.5 by 33 stent, deployed at nominal. And then our final IVUS run here at the end showing that the stent was reasonably expanded and the hematoma was secured underneath there with no further distal propagation. So ultimately a nice result at the end. So these were our final angiograms here. From the time we had the vessel go down to completing this was just under an hour. And amazingly, although the patient was having chest pain and hypertension from the ischemia, didn't develop significant bradycardia or heart block, and did actually very well. So several challenges along the way, which we can come back to, for reference with questions. But I would say the 3 sort of takeaways from this case were 1, sort of planning for success in terms of access and guide, depending on where your lesions are, how much support you think you're going to need. 2, when acute vessel closure, don't lose wire access. I had obviously not made it to chapter 25 yet, the manual at this point in training. And then a 3rd point, really showing the multiple uses of IVUS, not just in PCI planning, but really helping with managing complications. Thank you.
Thank you. Wonderful, wonderful presentation. And another option is to potentially, in cases like this, if you can get the wire in the right spot, which can happen, another option is to use a Stingray or even start it. So I don't know, Rhian or anyone, if you have any thoughts of what is your threshold for switching from wiring attempts to just re-entering one way or another?
No, I think having the skill set to know how to do Stingray is super important. It's just not something that's always readily available on some shelves, or the prep of them is also a little bit of a skill set to learn. So it's great if you have the opportunity to practice a few times. I think learning in an acute situation like this may be a little bit challenging, but certainly going to courses, being proctored, that sort of thing can help learn these skills.
Yeah, and this is a very experienced lab, with Kevin Cross, Brian Bregman. It's a very experienced lab. They have experience, so they have the expertise. But I mean, clearly here, getting the wire through, this is the way to go. So that was an excellent save.
Yeah, and that's definitely something that we, talked about and sort of reviewing the case afterwards, sort of if we weren't able to rewire, what would have been next steps? And yeah, Stingray probably would have been our option. Understanding that depending on where you re-enter, you may lose some side branches, some marginals along the way. So something else to consider.
And one last question coming from the audience. How about the cutting balloon, Wolverine, especially for the distal, when you put the second stent, it looks like it was a short segment of maybe hematoma. So the question is, could you have used the cutting balloon to drain the hematoma instead of putting another stent?
Yeah, we talk about this a lot. I feel like in our lab, our practice seems to be, if the vessel is big enough to stent, to go ahead and just secure it. If it's a, smaller vessel, or maybe just not a complex lesion down below that you don't necessarily want to put metal in, certainly can consider a cutting balloon. I feel like if we can stent, we typically don't.
Wonderful. Well, again, phenomenal case presentation. Thank you so much. And last but not least, Dr. Kamal will present the case. And again, thank you so much, Dr. Kamal, because I know it's, 4 or 5 o'clock in the morning in Egypt right now. So thanks for getting up early and for sharing this case for us. Thank you so much.
Good evening. I am Dr. Ahmed Kamal, Interventional Cardiology at Alainy Hospital in Egypt. I'm glad to present my case today, navigating a river with many currents and no compass. I have no disclosures. Our patient is a 49 years old male patient. He has no risk factors. He has a history of acute coronary syndrome 3 years ago, for which he underwent diagnostic coronary angiography with no documents, but he was told he has a complex lesion for medical treatment. 3 months ago, he starts to complain of dyspnea on less than ordinary effort. His clinical examination was unremarkable, and his ECG showed sinus rhythm with no Q waves and no significant SDT wave changes. His echo showed severely hypokinetic inferior and inferior septum, which is RCA territory, with impaired LV contractility. Ejection fraction was 45%. So our plan was to do diagnostic coronary angio, and as we can see here that he has a normal left coronary angiography. We angio the right system. As you can see here, there is a proximal to mid RCA lesion with TME2 flow. This RCA lesion had many differential diagnoses we'll discuss later. The team starts from the paraosteal site and divided into multiple channels that reconnect again at the distal segment. So our clinical challenge, our patient is symptomatic. He had well motion abnormalities in the RCA territory with impaired LV contractility. He has normal left coronary system with no retrograde collaterals to the RCA. Our proximal to mid RCA lesion has many differential diagnoses. It can be an old healed spontaneous coronary artery dissection. It could be CTO with recanalization through breaching collaterals, or finally could be a woven anomaly. So our plan was to do PCI to the RCA. We had to prepare our gear axis, which was to use the right radial 6 French axis. MDKasr, we prefer to start with the Yader right 4/6 French to avoid dissection to the ostium of the RCA on expense of less support. We used a MDKasr along 2.6 French, and the wires we start with run-through floppy wire as workhorse wire, and we have all the set of CTO wires on shelf. So we used first the run-through wire, which was directed into the upper channel, and then it passed into the RV branch and then to another side branch as shown here, but it cannot advance further. We then changed the direction of the run-through wire to pass into the lower channel, and it advanced more, but stopped again. We had to exchange it with the filter XTA over the E-long microcatheter, and it passed into a tortuous channel, but unfortunately, all the system was lost as shown on the right panel. We decided to change our guiding catheter to a more supportive one, but when we exchanged the guiding catheter, unfortunately, it induced radial spasm, and we have to give intra-arterial nitroglycerin and verapamil together with IV fentanyl. And with the use of a hydrophilic wire, we were able to pass this spastic segment and change our catheter with an AL guiding catheter. Also, the AL1 guiding catheter was a bit large. We don't have AL 0.75, unfortunately. So we had to do many manipulations until we were able to cannulate the RCA without damping of the pressure and adjusting the catheter to align with the lower channel we want to navigate. We also used again our E-long microcatheter and the filter XTR wire that passed to a certain point in the middle of the RCA and cannot advance more. We exchanged our wire with a cyan black wire to try to navigate these tortuous channels, and it advanced more in the RCA, but also stopped again before entering the healthy segment of the RCA. Now we had two opinions. My opinion was to continue using the sliding technique to try to reach the true lumen of the RCA. My senior said that it's best to use a penetrating wire, for example, a second wire, in order to pass to the true lumen. However, we go with my decision We advanced the microcatheter. We switched it back to the Fielder XTA wire, but however, it kept going to the RV branch until finally it managed to reach the distal RCA, as shown on the right panel. We injected contrast, but unfortunately it doesn't pass to the distal RCA to confirm we are in true lumen. So we have to do a tip injection that we confirmed we are in the true lumen, and then we advance the microcatheter. Now we are not sure that we are true lumen. We know we need to know the nature of this lesion. So we used an IVUS, and fortunately it passed through the lesion without any pre-dilatation, and we do a manual pullback, and it's shown here, starting from a distal normal RCA, then inside the lesion as shown now in these clips, and it moved back to the ostial of the RCA. Here the ostial of the RCA is healthy, as you can see. So when we examine the IVUS images frame by frame, we discovered that we are all the time in the true lumen, and the RT was divided into multiple compartments or channels, which is represented by the red stars on the left panel and the red circles in the right panel, and is separated by septies that are all enclosed inside the same adventitia marked by the green circle, making the diagnosis of woven anomaly more appealing. When we reviewed
this is fascinating. I'm just curious from the panel. Have people seen this? Have you done PCI on this vessel? Obviously, looked very, very, very weird on the diagnostic angiogram, and now it makes more sense. But have you seen this, and would you agree with the strategy of soft wire to try to get it through?
Yes, we use soft wires. We don't use penetrating wires. We had the two strategies, using slight technique or try to penetrate and reach the distal segment of the RCA. We had a conflict inside the cath lab, but we finally agreed to use soft wires to try to reach the distal without doing any puncture.
Wonderful.
When we reviewed the case reports about the woven anomaly, the passage of the wires inside these microchannels was easy in the case reports using the workhorse wire, unlike our case, which seems to be CTO requiring special gear. Now we felt safe to do pre-dilatation using NC balloon 2.5 times 15 with improvement of the flow. We deployed two overlapping drug-eluting stents from distal to proximal using PROMIS Elite 3.5 times 38 millimeter distally and 4 times 38 millimeter proximally. And as we can see, when we do the proximal stent, the early RV branch that's coming from the upper channel we was navigating earlier was lost. Most probably it's compressed by the stent. Then we do post-stenting IVUS, which shows well-deployed stent with slight malopposition of the stent struts at the mid-segment and compressed other channels that's seen here at the red crescent behind the stent.
Perfect. And delivery was easy? You said no problem delivering equipment in this vessel? Everything was simple?
Yes. Even traveling the IVUS catheter was done without pre-dilatation. It was easy.
Okay. Okay, wonderful.
That's really interesting. I would have thought you would have had to pre-dilate a little bit to get through there, considering it was so challenging to wire up front, but
we decided to use the IVUS before pre-dilatation to know the anatomy of this lesion, because pre-dilatation might change the anatomy of the lesion. So we passed the IVUS first without pre-dilatation, and it passed successfully with no problems at all.
Great.
We do post-dilatation using NC balloon 4 times 15 with STEMI flow and no complication as seen here. So our key learning messages: intravascular imaging is no longer a luxury, should be available in every cath lab and should be used whenever needed. Our case was not going to be diagnosed without intracoronary imaging, and better to use OCT in our case, but it's not available in our cath lab. Woven anomaly is a rare anomaly in which epicardial coronary arteries are divided into multiple microchannels that merge again into the main coronary artery. Teamwork is a key success for any procedure inside the cath lab. Thank you.
Wonderful. Wonderful. Thank you. Thank you, Dr. Kamal, again. Really appreciate the presentation. Again, something fairly rare. I don't think many people have seen this Hoover anomaly. I think there is also this theory that sometimes the vessels get occluded with a thrombus, and then during the recanalization process, you have this weird anatomy with the septa and the different channels without the vessel. So as we're speaking, the faculty is voting for the best one, and also same does for the audience. So a few more seconds about finding out the winner. And for the audience, you have this as a poll, and you can vote for which one you think the best, the same for the faculty, and then we will announce the results very soon. One of the other points, I think, for the last case is the importance of patience. So I think, as you said, there's people who want to go crazy and escalate to a stiffer wire and try to break the septa and make it through, which might be worse. But I think taking the time and using soft wires, that should be great.
All over the procedure to use a harder wire or more stiffer wire, but we resisted this temptation and kept on using soft wires in order to reach the distal RC. Yes.
Wonderful.
Thank you.
All right, and thank you all for voting. It looks like you have a fairly unanimous decision, and it is Dr. Espinosa. Dr. Espinosa, congratulations. There was a unanimous decision and a phenomenal case. We'll be sending you soon the $500 prize, and also the travel. Everyone, of course, everyone is a winner in the panel, and everyone gets a travel grant for CVI in July in Austin. But again, it was excellent cases, and I think we learned a lot from each and every one of the cases. I think it's time to let Dr. Kamal get an hour's nap before he goes to the cath lab. But again, thanks to everyone. I would like to thank once again Abbott, Boston Scientific, Cordis, and Medtronic for their support. And again, the next webinar is March 19th, my best PCI case. Look forward to seeing there. Also, many thanks to the great panel this evening, and thank to all the audience for attending. Thank you so much.